Welcome to live Q&A with the experts of Rome Foundation. My name is Tanya Murphy, Rome Foundation's Executive Director. Today's session is titled Gut, Microbiota, and Post-infection IBS. I'd like to introduce my co-host, Dr. Doug Drossman. Dr. Drossman is the CEO and President Emeritus of the Rome Foundation, President of Drossman Center of Education, and the practice of biopsychosocial care. He is also Professor Emeritus of Medicine and Psychiatry at the University of North Carolina at Chapel Hill, and is founder of Rome Foundation and is an internationally recognized scientist, clinician, and educator in DGBI and communication skills training. Dr. Drossman is joined by our Rome Foundation's board member, Giovanni Barbara. Welcome, Dr. Barbara.
Thank you.
Dr. Barbara has received numerous national and international awards throughout his career, as well as the Master Award in Gastroenterologist from the American Gastroenterological Association, and is currently president of the European Society of Neurogastroenterology and Motility. Many of you know Dr. Barbara from Italy, and he serves as associate professor from the Medical and Surgical Science Department at the University of Bologna. And I had the privilege of going to Bologna this past summer and spending time with Dr. Barbara and, of course, Mara Corsetti, and meeting Giovanni's beautiful daughters. So we're excited to have him here today with Dr. Drossman. So I turn it over to you, Dr. Drossman.
Thanks, Tanya. Welcome, Giovanni. Good to see you again by video. Dr. Barbara is, of course, as you've heard, well respected, particularly in the area of the microbiome, post-infection IBS. His paper done, was it 10 years ago, was keynote in giving us a good perspective, this working team on post-infection IBS before it was so well accepted. And I appreciate you being here because I think you're going to sort out a lot of questions. There are many questions about its utility and clinical value and how it's happening. Dr. Barbara has been a member of the Rome Foundation Board of Directors for at least 10 years now. And he's been an active person working with us. The IBS days every 2 years is something I would hate to miss, although I had to miss the last one because of a conflict. So welcome, Giovanni.
Thank you, Doug. It's a great pleasure for me to be here with you. Thank you, Tanya, for the introduction.
Well, good. Why don't we start? This is gut microbiota and PI-IBS. So let's start with what is post-infection IBS?
Yeah, post-infection IBS is nothing new. If we look, for example, at the past literature, there are many references to this condition. That is something that happens when you get an infection, an acute infection, could be bacterial, viral, or parasites. And if we look in the past literature, there are references, particularly in old books. I found a book that was published by Sir Arthur Hurst at the beginning of the last century, and he was the founder of the BSG, British Society of Gastroenterology, and he was describing this condition in soldiers that were coming back from campaigns of war in regions that were endemic for infection, for bacillary infection. And he described this condition that was typical. A proportion of these subjects that had these infections were returning back to England with colonic irritability. This was the term that Sir Arthur Hurst described for these people. All the tests were negative, and these people continued to suffer from bowel habit changes, abdominal pain, bloating, and so on. So he used this definition of post-dysenteric colonic irritability. This is a condition that nowadays we know quite well, and as a name is post-infection IBS. and is a condition that occurs in about 10% of subjects that have an acute infection gastroenteritis. And obviously, since not all the people that have acute infection gastroenteritis develop this IBS syndrome, then obviously there are risk factors that sustain this continuous symptomatology. So the risk factors are basically female gender, the long duration of the acute infection, and for example, being of a younger age compared to elderly people is another risk factor. And regarding this, regarding children, in the past, we had an experience here in Bologna. There was a tuna sauce that was contaminated by Salmonella enteritidis, and this tuna sauce was distributed to more than 30 schools in the region. And at that time, we thought that was very important to follow up in the following years. And this is what we have done. And now, since the infection was in 1994, it's 30 years now that we follow these now adults that at that time were children. And what we found was that the children were at higher risk of developing post-infection IBS compared to the adults that were in that particular cohort. So younger age, female gender, the presence of psychological factors before the infection, for example, anxiety, depression, are again risk factors for the development of post-infection IBS. And also it's important the type of infection agent, because for example, if you get an infection agent that affects the upper gastrointestinal tract, for example, we can think about Giardia, for example, that is a typical infection of the duodenum or jejunum, then is more likely that you get dyspeptic symptoms, post-infection dyspepsia. If you get an agent that affects mostly the lower gastrointestinal tract, for example, Campylobacter or Salmonella, Shigella, then is more likely that you get post-infection IBS.
Yeah, very, very interesting. You know, I worked about 15, 20 years ago with the Institute of Medicine they were looking at GI effects of soldiers in deployment during the Gulf War. And we basically found in our literature review that it was getting an infection in battle and the trauma of battle.
Yeah.
That was the stress that led to a very high development of post-infection IBS. By the way, I remember when you talk about IBS, the Quarterly Journal of Medicine, there was a paper, a review by Chaudhary and Truelove,
Yes,
that noted that 25% of patients had an infection, and that was just a clear observation way before it was accepted as a factor in IBS.
yeah, definitely. I remember very well that paper was a seminal paper. And what we have done after those initial observations is to refine much better the risk factors and the pathophysiology, because that is also important, and also the new concept that I would like to introduce, that probably the infection, this is my view, that the infection is a trigger of a predisposition to develop DGBIs. In other terms, if you look at the literature, every acute inflammatory insult to the gut can lead to long-term development of IBS symptoms. For example, if we look at celiac disease, patients that undergo a gluten-free diet have a high risk of developing, even if the inflammation has gone away, to develop post-celiac disease IBS. This is around 20 to 30% of the subjects, and there is good literature about this nowadays. Again, if we look at quiescent IBD, and Doug, you know very well this topic because you published extensively about this in the past. Also, patients that have undergone resolution of the acute inflammatory response have a high risk of developing post-inflammatory IBS. The same applies, for example, to acute diverticulitis. And so I think that the inflammatory trigger is the factor that is in a way determining in a predisposed individual with all the risk factors that we mentioned before, the development of long-term symptomatology.
What about the baseline gut microbiota? Is your profile important for symptom generation in IBS?
Well, I think that the microbiota is very important. I think that now we have all the methodology to understand and characterize the microbiota in a very profound way. And that started, I would say, around 15, 20 years ago when the culture-independent technologies to assess gut microbiota appeared in our field. So with that, we could confirm an hypothesis that was around since a long time ago, that the microbiota was important in IBS, but never demonstrated in a very efficacious way, because with the culture we could grow in the laboratory only a small proportion of the bacteria that are typically anaerobic, so they don't grow very well in the presence of oxygen. So with this culture-independent techniques, we could detect a lot of changes in gut microbiota in patients with IBS and other GGBI. So now we have a lot of evidence suggesting that the proportion of patients with IBS have indeed changes in gut microbiota. The problem in that literature is the reproducibility of the results that is not so good. And also, I think that another important problem is that 90%, I would say, of the literature is based on fecal samples. That is a problem because fecal samples are not very reliable. There is a very good study that has been conducted in Belgium and in Holland, here in Europe, and they identified the factors that confound the results in gut microbiota research. These were listed are around 70 factors, and the top factor, the most influential factor, is what? The Bristol-Stowe scale. So if you have a faster transit or a slower transit, then the gut microbiota changes completely. So probably it's more important if we look at the gut microbiota on site, so in the colon or in the small bowel with biopsies. And there is a very interesting study that has been published a few years ago that looked at these so-called biofilms. These biofilms are probably the mucus and that layer that is on top of the epithelial cells. So if you take that, then you find very important changes in gut microbiota. So, for example, a change in biodiversity, a reduction in this very important factor that is synonymous of gut health. You see, for example, an increase in primary bile acid in the colon. That probably is important for diarrhea in some of the patients. You see the growth of the so-called pathobionts that are the bad bacteria in the gut, a reduction in the good bacteria. So I think that the next step is to characterize on site in the colon, close to the epithelial cells, where these bacteria have their influence on the physiology of the gut, rather than looking at the feces. That is not very reliable way of looking at gut microbiota.
Well, this is a key point because, I mean, I'm sure you in your practice, and certainly I get patients with diarrhea or constipation or IBS, and they come in with like 20 pages of their microbiome from a stool sample. I don't know what to do with that because they're isolating things and telling you this is bad and this is good. What do you tell them?
Well, Doug, we just recently published in Lancet Gastroenterology, just last week, an international consensus statement on microbiota testing in clinical practice. So I think that these are very good instruments for research, but probably we are not ready for prime time in clinical practice. And there is a list of pitfalls with these tests that we need to take in consideration when we receive this type of outputs. First of all, many people, many physicians are not ready to understand what is written in these reports. So there is a lot of data, but probably many of us don't have the knowledge to understand this type of reports. There are also many issues about sample collections. So each laboratory does it in a different way. So some laboratories say give us the fresh material, some say frozen, and so there is no consensus on how to preserve the sample. Collection of clinical data in the reports is very weak. We don't know what these patients have. Also, the methodology that these laboratories apply to gut microbiota is different from one laboratory to the other. So in this paper, we try to say what we should do for the future and what we can get out of these reports. And for the time being, we discourage, for example, patient self-prescription for no reason. And also we think that we need to educate the physicians to understand much better what we can get out of these reports.
So is there a way to diagnose dysbiosis in patients, aside from taking biopsies of the colon?
Well, the ways are there. In other terms, the technology is available. I think that there are some pitfalls, and the other big issue is that probably we are not good enough to characterize dysbiosis with the old methodology. For example, breath tests. There is a misuse of the term SIBO, I think, small intestinal bacterial overgrowth, based on breath testing. Breath testing, we have published a lot about this in papers showing that the accuracy of breath tests to diagnose dysbiosis is very, very low. So is a concept that is probably there. Probably many people have dysbiosis in the small bowel, but the tests that we are applying, breath tests in particular, are not good enough to detect these changes in the small bowel. So I think that there are some difficulties in the diagnosis, particularly based on the fact that the sampling is very difficult. The small bowel we cannot sample. The large bowel we can sample only with the feces. We cannot ask all the patients to undergo colonoscopy. So I think that still we have many problems in order to characterize well and diagnose well dysbiosis.
Yeah, it sounds like we don't have a really good biomarker for this, but still clinically, we deal with it. We give them probiotics, we give them antibiotics, as you know, you don't have to, the false negativity rate is high, the false positivity rate is, and many of us treat antibiotics for IBS empirically. We don't even do a SIBO test. So how effective, since it's being done empirically, how effective are the probiotics and the antibiotics, and are there any problems with doing that?
Yeah, quite often, Doug, in research we see, and in clinical practice, we see that sometimes we have the therapy that is already available without any pathophysiological data or diagnostic data, and we all understand that probably microbiota is important because we already have the answers regarding the modulation of gut microbiota. So one of the simplest way of modulating gut microbiota is when we sit down to eat. So the diet is probably the most powerful way we can modulate our gut microbiota. So, for example, there are data in the literature that suggest that if we change our diet, for example, if we start eating more proteins compared to carbohydrates, then within 48 hours, we can change completely the gut microbiota in our intestine. So that is a very powerful way of modulating gut microbiota. Unfortunately, nowadays, everyone is on a diet. Everyone is doing, self-made diets, or follow FODMAP, low FODMAP diets, or gluten-free diets. But all these diets may have detrimental effects on gut microbiota. So we should consider that we have to provide a good source of growth of the good bacteria in our gut by providing enough carbohydrates to this gut microbiota. So diet is very important. We understand that, and we have to work a little bit more to understand which is the good diet for the IBS patient. But the other way we can intervene is by modulating gut microbiota with probiotics, with non-absorbable antibiotics, which is another way that is very effective, at least in a proportion of the patients. And also, this is probably the future. We don't have enough data, but the most powerful instrument in the hands of physicians to modulate gut microbiota is probably the fecal microbial transplantation. So regarding probiotics, another big mistake that we are doing nowadays is that we consider probiotic as a single entity. But within that entity, we have species that behave in a very different way. I always make an example. E. coli, for example, could be a very bad pathogen for the gut. For example, enterotoxigenic Escherichia coli can bring you to the hospital because of very severe diarrhea and bleeding. However, E. coli Nissl is a probiotic. So when you move in the species very little, you can have very harmful bacteria or very good bacteria. So probiotics are not all the same, and this is a problem. And the other problem is that DGBI are very heterogeneous. So finding the best probiotic for that particular patient is very difficult. And we have to go through the literature and see at the single trials rather than looking at meta-analysis. And if we do that, then we find very interesting results. For example, what we have found recently in a trial of a blockbuster, I would say, probiotic in Europe, then they asked me to do this trial. I said, this is very risky because in IBS is a big risk to do a trial with the probiotics. We did it, okay, and the results were not very good. So the placebo was the same as the probiotic. But fortunately enough, we collected the feces before and after the trial. And what we found was that within that population of IBS patients, there was 25% of the people that were enriched in their microbiota with a particular strain that is called Collinsella aerofacens, and those were responding brilliantly to that particular probiotic. So personalization of the therapy and identification, probably with biomarkers in the future, of those who respond is probably the way to go. But we are not ready for that.
Sounds like we'd be moving toward profiling the bacteria with artificial intelligence or something.
Exactly.
To select it out.
Exactly, yes.
Well, our time is almost up. Just on the clinical realm, so many patients do take probiotics just empirically. Do you have any recommendations for them, or to be careful of anything, or is it just all okay?
Well, first recommendation is that if we look at meta-analysis, they are positive. So a benefit probably can be obtained with probiotics. So I would say that given the fact that probiotics are very safe, except certain subjects that have immunosuppression or are very sick or have a very big increase in gut permeability, in those cases, I would not use them. In all the other cases that are the majority, particularly in IBS, I would say that probiotics should be used. And if they don't work, maybe shift to another one, but I would give it a try.
Okay. Our time is just about up. Any final words, anything that you would like to leave the audience with?
Well, my final word is that microbiota is a very fascinating field of research, but I would say that beside the obvious enthusiasm for this field, I think that we are in the very early stage of the learning curve, and we need to get more and more and more data before we have the answers for the clinic. But I think that with personalization of therapies, identification of biomarkers, I think that microbiota will become a major field of interest in our daily practice.
Well, Giovanni, thank you for your participation in the field, building the field, and thanks for coming on our session today. Tanya, back to you.
Thank you both so much for your expertise. Thank you everyone for joining us today on live Q&A with the experts on RIM Foundation. Hope everyone has a great week.
Thank you very much.